very happy to be here. I've been a strong believer in this whole idea of an ecosystem in all the innovation efforts that we do. The question has always been, how do we go about doing it? How do we go about doing it effectively? You also know that while we're all players in the same system, I think a key thing to understand is that it's not always the case that incentives are always aligned. And the ability for us to align incentives is key to collaboration, is key to successful innovation, and is, I think, the key to allow us to really push the boundaries of the innovation as well as the eventual implementation of the innovation in ways that actually ultimately benefits everyone. Okay, so keep that in mind. So while we all have our own sort of like interests that we need to safeguard and all that we're all trying to push, understand that if we see this as, I'm trained as an economist, if you see it as a repeated game and an ecosystem that we want to build together, then there's a lot more possibilities in terms of what we can achieve. So my talk today, the title is actually about how we are co-creating the future health system. And I, like I say, I believe in public-private partnerships. The question is, how do we go about doing this? But before I go into more detail, I thought it's useful for us to understand that where the trend of health systems are going towards. Even before COVID, MOH had actually issued a 3 beyond. So this has got nothing to do with me. It was well before I joined MOH. And there was already an understanding that in order for healthcare as a system to remain cost-effective, while sort of like delivering good clinical outcomes, we had to start thinking about not just healthcare, but how do we maintain health? We had to start thinking about not just about the hospital, which is about acute care, but about the delivery of health within the community. And of course, within that construct, how do I ensure that it's quality, not just quality, but actually the value? It's not just about getting better quality for everything you do, but how much did it cost? And was that cost justifiable? Where else could I have spent that money such that overall outcomes for the ecosystem was actually potentially better? Of course, I also want to talk a little bit about some of the things that came from COVID. Obviously, I was very involved in it. But a few things I learned, I realized that public-private partnerships can work. I worked with many companies in that process because they were the ones who moved the fastest. The question is, how do we help clinicians trust what the companies are trying to do? How do we ensure that even the GPs themselves, you understand the GP market in Singapore, a lot of them became GPs, and some of you might be GPs as well. A lot of you become GPs because you couldn't deal with the bureaucracy in the hospital, so you left, right? So how do you let these people trust the bureaucracy, trust the system, and want to work with the system in order to have better outcomes? Digital health was actually obviously a huge value as well during COVID, because at some point in time, when we couldn't cope with the physical capacity, the digital players stepped in to actually help us to do things. When we could no longer do contact tracing manually, we basically introduced Trace Together as a contact tracing app. Yes, it is not 100%. The human in the contact tracing office, tracing down every single individual, is still going to be more comprehensive, but frankly, we didn't have the capacity anymore. And if at the point in time I could do 80%, that's better than I'm doing 100% of 10%. Okay, so these are some things to keep in mind when we think about digital technologies. How do we help to motivate why they're using it? Of course, some of the other things like crisis making technologies acceptable, regulatory innovations, being valuable enablers, and of course here working with HSA said, okay, this is not, I'm not very comfortable with this, but I guess we have to go, and we go. But what we then did was we helped them to put in a very strong post-market surveillance monitoring system, which is a good outcome that came out of this. And of course, finally, I wanted to highlight that as part of COVID experience, we realized that individual responsibility can be a very powerful force multiplier. So all this move towards preventive health, the role of the individual and what the individual does, how do you convince the individual that what you are asking them to do is going to be good for them, I think will also be key. So just to give you some sense of the things that we introduced in COVID, I won't go through this in details, but really some of the things that you see today were things that we introduced during COVID, including the use of robotics, AI-driven chatbots, telehealth that we now see a lot more in the polyclinics and so on, and even the allowing of MediSafe for use in some of these settings and so on. I think came about because we used these tools during COVID, and we had certain confidence in its ability to actually help us to do the work. And of course, many of these things we are now pushing out in preparation for an aging population, that we know will mean more healthcare needs in the face of a shrinking working population, which means less doctors and less nurses. And of course, with that, the need for us to figure out how to do things slightly differently. So you noticed just now I said before COVID, BC, right? So now I want to move into the future. I call it the year of the digital, or the future that's actually based on future health systems, AD, and of course made possible by public-private partnerships. But I guess what I wanted to maybe spend this time talking about, because there'll be other people who will talk later on as well, is to say, actually, what are we talking about when we say future health system? I have used this term, it kind of came to me over time, but as I found these terms, I found them very attractive. I say that what we're doing in Singapore right now with Healthier SG is population health. In other words, I'm trying to say I will manage everyone, including those who are not ill, as a population, and actually think of the delivery of health for the entire population. But population health really is just the beginning. It is the beginning in terms of how we actually understand who our population is, what are our baseline conditions they have, and how they then begin to develop disease over time. Okay? And of course, when I look at how the disease develop this disease, what type of interventions the GPs actually help to administer, the outcomes of those interventions, and of course, we know GPs have slightly different practices. It's not like every GP does exactly the same thing. The different practices of different GPs across different types of people becomes a natural RCT that's actually happening on its own. Okay? And that natural RCT then allows us to have much better data that supports precision health. I now know that over time, what type of interventions work better for certain groups of population, what doesn't work for better for what works well for others, what type of characteristics characterize stratification of the population, what should I be looking for, and so on. So that allows me to achieve precision health to a much deeper degree. But after I achieve precision health, the real saving comes when I say, okay, these are the people who are really very ill now. These are some interventions that didn't work, so let's make sure I now apply the right interventions. But what did they look like 10 years ago? How do I stratify them at the 10-year-ago mark and decide on my testing and diagnostic strategy such that I screen better and I screen in a very cost-effective way? Because we all know that actually diagnostics are useful. I've spoken to even the likes of Grail and so on. But the question I asked them was, I believe in your technology, but can you answer the question, when do I test? Who do I test? How often do I test? They actually have no answer. Okay? But those are the answers that we need. Because if I can't answer those questions and have a price point that allows me to demonstrate cost effectiveness, then none of these diagnostics are ultimately useful. Right? So understanding that the population health allowing us to achieve some amount of precision health, but ultimately the biggest holy grail is actually how do I use that data to design the preventive health system such that we are really achieving cost sustainability as a whole. And of course, down here I have some terms that actually go with it, and then maybe I'll elaborate a little bit on each one. So population health really, we have to think in two dimensions. One is actually setting-wise. Do I go to the GP? Do I go to the polyclinic? Do I go to the hospital, community hospital? How do I decide where is the right place to place an individual? The next thing is about accountability. Over time, how does a patient progress? Whose fault was it, or whose sort of like a credit was it that they improved or didn't improve? Both of those are actually dimensions which are very necessary to track, which, if you ask me, it is not possible for medical device companies or pharma companies to do on their own. The entire system must kick in. The government has part of the data. I won't claim that the government has all the data. Some data lies in the private health providers, including GPs. Some may even be with the medical technology companies. How do I bring this data together in a way that everyone understands will benefit everyone in the process, but with the right level of trust, right level of governance, right level of attribution of who is contributing, such that everyone is willing to put their data in for us to derive some of this understanding of what's happening. In the space of precision health, because many of you are familiar with the concept of companion diagnostics and so on, and much of this will potentially be based on understanding of the individual. one advantage that Singapore has is that if you look at our population, we have the Chinese, Indian, Malay populations. The Chinese population, actually, if you think about it, genetically covers most of the Northeast Asia populations. The Indian population, we have two. We have the South Indians and the North Indians. The South Indians and the Malays are actually more similar in terms of their genetic backgrounds, because these were the seafaring people who actually basically conquered all the islands, the Southeast Asia islands, as well as all the way to the South India, all the way north even to Japan, and down to the South Pacific islands. Right, and they have you look at it, a similar grammatical structure in the way they speak. And of course, then with the North Indians, which are perhaps representative of the same Central Asians, Persians, and so on. So you look at the population in Singapore, we easily cover 50 to 75% in terms of genetic similarity with the Asia Pacific populations. So if we can dig deep into the data in Singapore and find those insights, many of these insights are potentially applicable across Asia Pacific markets. Finally, I wanted to talk about preventive health. Preventive health, currently, in most people's minds, is really about, what do we do in terms of the actual clinical or maybe even exercise and diets and so on. But I wanted to actually highlight that in the preventive health, in the digital era, there is a potential of even what we call digital biomarkers. You have seen some of them outside just now. Okay, digital biomarkers rather than the biochemical biomarkers that we are used to. And more importantly, with those are the tools for behavioral nudging of the individual. When someone sees something and he's given a prompt because, okay, based on this thing, you better do something, they begin to change their behavior potentially, because this is now specific to him. It's all well and good to say, please eat healthily. Everyone understands that. But if because my glucose monitor says that my sugar is too high, I should stop eating, carbo for the next meal, I do it. Because it is mine, it's specific to me, right? So how do we make sure that that's actually part of what we think of in terms of preventive health? But of course, with that larger backbone of or backdrop of actually what we think we're trying to achieve, I want to talk about a few areas where I think there's a lot of potential for the companies to contribute the technologies that matter, as well as to actually sort of like understand that if you see yourself in this larger construct that I just illustrated, then you must think of how you play as part of an ecosystem, and don't try to play as an individual company. Because we will all be trying to do a lot of things, but in the end, none of it will stick, because none of it will be convincing enough to the people who finally make a decision that I'm convinced that this way of doing things is really going to have the kind of impact that we have. Okay, so then how do I make sure that I'm able to demonstrate impact in a way that can be very convincing? First, I need to have a very strong health data backbone. Under the Precision Health research precise that we've set up, we have already collected the 10K population in Singapore. We are doing 100K right now. Hopefully at some point in time, we may actually say I'll collect 1 million people, genome-wide sequence. Okay, but that's not the full set of the omics data that we have. We also have the proteomics and metabolomics data, which is an epigenetic characteristic of the genes of individuals, which is affected by the environment and the kind of things they choose or choose not to do. Then we actually have what I call the electronic health records, which are, I call, state-changing occurrences. When a medical, when a health episode occurs to you, your body undergoes a state change in some sense. And each state change will change the trajectory of how your body is going to react. Right? So understanding the root, the genomics, the environment, which is something that you experience, the state changing sort of like data, and finally, of course, the daily activity records, which comes from all your Fitbit. Of course, HPB has all these trackers that we've actually put out. How do I bring that data into this data stack as well to help us to do the analysis? Now, of course, you realize that when it comes to the Fitbit data, well, every second you have something. The question is, do you really need every second part, or do you actually just need trends across a period of time? We have to figure out what is the frequency of the trending that we need, but yet the instantaneous data itself has its value, because at some point in time, this instantaneous data may have profiles that give us reason to actually do an immediate intervention for an individual at that point in time, but the system doesn't need to know. The system just needs to know what patterns there are out there, and when they see a pattern like that in your device, I will tell you something that you can then do something about. But that allows us to safeguard confidentiality of the individuals. In other words, I don't need the data of the individual on a daily basis. but I need it initially for analysis. And after that, I need to be able to have access to you, maybe through an edge AI that I deploy to a device to help you to manage and to help you to actually address any catastrophic things that might be occurring to you at that point in time. Okay, so keep that in mind. Of course, with that, the question is actually, how do we then think about the electronic medical records? Are they the way that we're used to right now as the Epic within the hospitals? Or do I need to start thinking about, is there a way for us to hold individual dockets of health for an individual? Because in my head in MOH, other than looking at the IT systems, I also look at cybersecurity. Okay? And when I have systems that are very, very well connected, when collecting data from a lot of places, each one is a door that someone can break down. Then the next question I ask is, who is looking after the door? Are they a good policeman, or are they like the 60-year-old, okay, no, maybe it's a bit biased, but some of your security workers that they're just hired so as to look like someone is there, but really they might be like nodding off and falling asleep. No, so I think we have to be quite clear. The architecture may have to also change depending on how we actually think about it. And of course, some of these daily VSM data streams that I talk about, how do we manage that? And beyond the wearables, are there ways of actually leveraging community health stations to actually collect some of these things as well, such that the frequency is still higher than the incidents of coming to the hospital, but not as high as a wearable. And if you think about the active aging centers that we have, that's where we think we are trying to aim towards. Of course, then there are some of these devices. I won't go into detail on each one. The personal digital devices I talked about, MDOTs, which are the connected IT systems that we might actually have. That's another area that we want to think about. The good thing about MDOTs, which are deployed into homes, is that if you think about it, currently a doctor, you go and see a doctor, the doctor measures you at the point when you show up at the clinic. He looks at you, you tell him about some ailments you have, he's like, but your stats look correct, look fine. What are you talking about? I don't understand. So you religiously collect some of this stuff yourself. He looks at it, but he's not sure whether he can believe it, because he's not sure whether you know how to do some of these things yourself. And in the end, all this data is like, so what do you bother? Is there a way for us to collect some of this data such that it becomes much more automated and trustable, that reduces the healthcare worker load, but actually provides for much better prognosis on the part of doctors? I think that will be key. One part I want to talk about this is the idea of non-invasives as well, because this is something that's coming up in the technology space. Right now, a lot of the things you have to attach, you have to put something, there's a new class of technologies that's looking at non-invasive observing from a distance. Still very early stage, but that's one area that we should actually look at as well. Finally, of course, we need to think about the health touch points, because the health touch points will vary depending on the nature of what we roll out. I talked about some of these things already just now, so I won't elaborate, but community partners includes the GPs, but also the community medical posts, which are like potentially active aging centers. Telemedicine is also a very useful way of doing it. We don't have enough doctors if we're going to provide care in the community for me, the doctor, to travel from home to home. We don't have enough nurses either, but we have a lot of nurses who have quit the public health system and gone on to do other things. Now, we can imagine a situation where some of these people are brought back on a, task basis to go into a few homes that are close to where they live. They go in there and do some of the whatever that might need to be done in the patient, and if there's a need for a doctor, I zoom a doctor in. Right? That kind of system could potentially be a lot more cost effective and allow us to still deliver care in the community. And of course, finally, as we think about community, we can't just be thinking about the physical community. The question is actually whether the virtual communities themselves can be part of the force that we actually try to gather to help everyone stay disciplined to what they're supposed to do and so on. So that's another area to think of. Finally, I wanted to just end off with this slide about measuring value, because I've already in a way talked about this earlier on. How do you actually think about value? How do we ensure that whatever technology we introduce ultimately is actually cost effective? If all you think about it, any medical device that you introduce, unless if it's cheaper than what is already in practice, must increase cost. So even if there's no device used today, I introduce a medical device, it will increase cost if nothing else changes. So the only way that a medical device can reduce cost if there is a process change as well. in the institutions. But all of you should also understand how difficult it is to make process changes in institutions, because it's about quality and safety. I change something, am I really going to maintain quality? Is there going to be patient safety issues? No one is able to tell anyone anything. And so when no one can tell anything, nothing gets adopted. Okay. So we need to think in a system level. We need to think about how we convince doctors that there is a technology and a new way of doing things. And let's try it out among ourselves, where we, as the doctors who know what's happening, can decide whether or not it really makes sense. The saving that we will tell our doctors is that it will help you to spend more time per patient, and it will help you to go home earlier. Those are the things we need to tell the doctors so that they'll be open to trying new things. But if we can't achieve that, then the technology itself will also not be cost effective. So anyway, I leave with that thought, life cycle view, clinical outcomes, and so on. All this, remember some of the things I just said, which potentially could help to get a lot more doors open. Thanks.